It's blocked, doesn't go. Hello? Okay, thank you. So the acute subdural hematoma are one of the most frequent surgical evacuation. And whenever we have an acute subdural hematoma, we have this situation. So we can evacuate the hematoma and replace the bone, as we have done in this case with a good outcome, or we can evacuate the hematoma and decompress the patient, as we have done also with good outcome. So there are two possibilities, and there has been two very important papers recently addressing the same issue. This is a multi-center study coordinated by Cambridge with many other countries involved. And as you see, it's called the Rescue ISDH. And this randomized study between patients in which the acute subdural hematoma was only evacuated and patients in which we did evacuation plus decompression. This is the first randomized study in head injury, in all the history of head injury, where 40% of patients were not from Europe or US. And actually, the first recruiting center was in India, Bangalore. So it's the first study where countries like Pakistan, India, Malaysia were involved in the study. Different from the previous studies, where almost all patients were in Western countries. The process of randomization took place intraoperatively. Why? Because if the brain was swelling outside the cranial cavity, the patient was not randomized and the decompression was done. So the aim of the randomization is between patients in which you are not sure about what to do. Patient in which the brain is going down after hematoma evacuation and you are not sure about, do I leave the bone or I decompress the patient? This is the group of patients which was randomized. The outcome scale, the Glasgow outcome scale, was assessed 12 months later, not 6 months as usually it is done. Why? Because we have done a series of studies which showed that the outcome can improve for 12 months. Why? Because we have hydrocephalus, we place a shunt, we do a cranioplasty. So in a longer period, these patients are still operated and treated. So we shifted the outcome from 6 to 12 months. The results of the study are flat. What does it mean? That there is no statistically significant difference between craniotomy and craniectomy. So the number of patients who had an unfavorable outcome in the two groups was not statistically significant. I repeat, the two groups are made by patients in which the surgeon is not certain about what to do. In patients where the brain was swelling, there was no randomization. So the additional surgery was performed in a higher proportion of patients with craniotomy, about 16 per 17, one patient in 7, who had only craniotomy with bone reposition. After a few weeks, a few days, was reoperated and decompressed. But in the group of patients who were decompressed, we had far more wound complications, so infection complications. So the two groups were different. The group of patients with bone reposition had one possibility in 7 to be reoperated because of the new decompression, but the patient who had decompressed had far more infective complication. This is another study was running at the same time in the center TBI group, and this is the collection of patients was done before the other study. This is the group of patients, the same group, acute subdural hematoma, 91 operated and decompressed, 245 operated and decompressed. So this is the groups, and again, the results are the same. The functional outcome at 6 months in this study was similar in the two groups. So in the group of patients operated and decompressed and operated only, we had similar outcome. The most interesting features of this study was these are the centers, the large variability between centers. There were centers who were almost decompressing everyone, and centers who were not decompressing anyone. So there was a big difference in Europe between centers in the predisposition to decompression, but the results were similar. So we found that being aggressive or not was leading to the same results. Remember that we are talking only about decompression related to acute subdural hematoma. We call it primary decompression. The conclusion of these two new studies is that whenever you have an acute subdural hematoma, the decompression is not a must. You have to consider the patient, the cases, and the site, because we cannot offer better outcome but by associating hematoma evacuation and decompression. Obviously, only in the patient that we have studied, not in the patient where the brain is swelling. Are there any alternative to decompression? So can we avoid surgical decompression and operate the patient to decrease the pressure? There are two techniques. One is called hinge or floating craniotomy, which is you raise the bone about 1 centimeter, 1.5 centimeter, up to 2 centimeter. You just raise the bone. You don't take it off. You don't put in the bank or in the abdomen. You leave it there. You raise it. And when the swelling is gone, you put the bone back. There are different techniques. This is published in Brazil. You see they split the bone into two parts. This is China. They put up the bone with screws, and this is what we do. There is a special device called Rialto, which keep up the bone for 1.2 centimeters. But these are different ways to do the same thing, raising the bone without taking out the bone. And this technique is very much promising. Unfortunately, we don't have enough data at the moment. We don't have good randomized trials, but the technique is promising because many papers have shown that the volume that you gain is enough to decrease the pressure. So it's a promising technique. The other technique is so-called cisternotomy. It's the Hyperion, we speak today about it. It's not only to decrease the pressure, but also to avoid the CSF to enter into the brain and contribute to the edema. The technique is used in some places in the world already, and there are many papers. I just show you also a book was just published recently, and I show you the last 3 review about cisternotomy. This one is a a mixture of cystonotomy review and advice how to do it, with a description of the microsurgical approach to the basal cistern, which is not straightforward, but it's one of the techniques that we have in our hands. This is an Indian review just published in World Neurosurgery in September, that we have data about decreasing mortality rate and decreasing the time for ventilation, but they are asking for more studies. And the same, this is a review done by our German and Swiss colleague, just published to September 2024. So 3 recent reviews say the same. So it's a promising technique, it's interesting, has been already applied in many parts of the world, but we don't have that much data for this. So the end of the story can be that still there are no randomized clinical study, both for hinge and cystonotomy, but they both are very promising. The key point, just to finish, is when to use decompression. Decompression is a last resource. It's at the end of the therapeutic scale. This is the staircase. When you treat brain injury, decompression is the final solution, when you cannot do anything else. And as we have published, and many others have published, it cannot be used in more than 5% of patients with a severe head injury, because all the other cases can be simply operated or treated medically. If we use decompression in 75% of our patients, there must be something wrong. So the issue is we know from recent studies that decompression will decrease the number of patients to die, but will increase the number of patients with severe handicaps. So we know that there is the possible way to get more patients alive, but with more severe deficit. So we need to speak with the families, explain to them, and we have to decide in favor of decompression. This is the message from all the studies we have done. Whenever you don't have other alternative, is a life-saving procedure. It's not something who can be used in the flow chart of the cure of the patient. Thank you.